Ever had that searing leg pain that just hits you mid-run,
Yeah.
forces you to stop, right?
Yeah.
And then just like that, it's gone. It can be maddening if you're active.
Yeah.
Today, we're going to dive into a condition that might be the reason. Chronic Exertional Compartment Syndrome, CECS for short. We'll be digging into Rutherford's vascular surgery and endovascular therapy, the 10th edition, as our guide here.
Great resource.
Our mission, really, is to help you get a clear picture of what CECS is, why it might happen, which sounds a bit mysterious, how doctors figure it out, and, what can actually be done about it. Think of it as your shortcut to being really informed on this.
Exactly. We're going to try and break down CECS. It's fundamentally what we call a non-atherosclerotic cause of claudication.
Claudications, that's exercise leg pain, right?
Yeah.
But non-atherosclerotic means not the usual artery hardening.
Precisely. It's not about plaque buildup like you see often in, say, older individuals. CECS typically hits younger, very active people. Think athletes, military recruits, folks really pushing their bodies.
So it's directly linked to the activity itself.
Absolutely. The key thing, the hallmark of CECS, is that the pain is consistently tied to exercise. It's reproducible.
Reproducible meaning?
Meaning it pops up after, roughly the same amount of time or distance or the same intensity of workout. And it stays within the affected leg compartment.
Interesting. Is this a relatively new thing doctors are seeing, or has it been around?
Well, it's fascinating, actually. The sort of earliest description that sounds a lot like CECS seems to come from Edward Wilson. He was on the South Pole expedition back in 1912.
Wow, 1912.
Yeah. His diary describes symptoms that really sound like anterior compartment syndrome, even way back then in those conditions. So it suggests maybe it's not new, just wasn't always specifically recognized.
The South Pole. You wouldn't expect that origin story.
Not at all. But the first sort of formally published case we'd recognize today, that was G.E. Maver in Scotland. He described a soccer player, professional player, who had this pain in the front of his legs during games, plus some tingling in his feet. And Maver actually did the first fasciotomy for it. He even used a fascia lata graft, which is a piece of tough tissue from elsewhere, to patch things up. And the amazing part, the player went back to his pro career.
That's pretty incredible for an early attempt. So what's actually going on? What causes it?
Yeah, this is where things get a little less certain. The exact cause, still unknown. But the main theory, the leading one, is about increased pressure inside those leg compartments, intra-compartmental pressure, or ICP.
Okay.
The thinking is this high pressure temporarily reduces blood flow, causes ischemia to the muscles during intense or long exercise.
Temporary lack of blood flow sounds painful.
Oh, it can be, definitely. Now, it's crucial to separate this from acute compartment syndrome. That's an emergency where pressure stays dangerously high.
Right.
In CECS, the pressure builds up, causes pain, but then it does come back down, and the symptoms go away when you stop exercising.
So pressure up with activity, pressure down with rest.
Pretty much. And why does that ischemia happen? Well, a few ideas have been floated. Maybe the arteries spasm or tiny blockages form in the microcirculation, or maybe the vessels just collapse under the pressure.
Makes sense, theoretically. But what starts the pressure buildup?
Well, we know muscles naturally swell during exercise, right? They can increase in size maybe 20% just from increased blood volume.
Okay.
So some think maybe the fascia, that tough casing around the muscles, gets thickened over time. Or maybe the muscles themselves just get too big, hypertrophy. The compartment can't stretch enough to accommodate the swelling muscle.
So the muscle swells, but the container is too tight.
That's the basic concept. But here's the wrinkle. Some MRI studies looking for signs of that ischemia, they haven't always found it, even in patients with proven high pressures.
Really?
Yeah. Which suggests maybe the pain isn't just about lack of blood flow. There might be other factors, things we haven't quite pinned down yet.
So who tends to get CECS? Are there specific risk factors?
It's overwhelmingly seen in young, physically active people. Some things might increase the risk. Anabolic steroid use, for example, because that promotes muscle growth.
Right.
And also sometimes abnormal running mechanics, biomechanics that put extra stress on certain compartments.
How common is it, though? If someone gets leg pain with exercise, what are the odds it's CECS?
Well, the numbers vary quite a bit in studies, maybe 10% up to 60% of people with exercise-induced leg pain. That range probably reflects different ways of diagnosing it.
Okay, so diagnosis matters.
Definitely. But one study looked at 150 athletes with this kind of pain, found CECS was actually the most common diagnosis, about 34% of them. Tibial stress fractures were next, around 25%.
That's a pretty big jump. Where does the pain usually show up?
Most often, it's the anterior compartment, the front of the shin and the lateral compartment on the outside. About 70 to 80% of cases, and often it's in both legs.
Bilateral, okay.
Yeah, doesn't seem to be a major difference between men and women. And the typical age people first notice it is around 20.
You mentioned the military earlier. Is it a big problem there?
Yes, it definitely is. A big review over 8 years found an average rate of about 0.49 cases per 1,000 people at risk each year.
That seems significant.
It is, and what's worrying is that in that group, surgery was mostly for the anterior and lateral parts, but a lot of them had symptoms come back, something like 44%, and almost 28% couldn't get back to full beauty.
Wow.
Surgical failure seemed linked to complications, ongoing activity limits, and just symptoms that didn't resolve. So yeah, CECS is a major cause of lower leg disability in the military population.
That's tough. What about specific athletes?
Runners and soccer players seem particularly prone to it, and there's some hint that if the deep posterior compartment is involved, especially in younger people, the surgery might not work as well.
Okay, so someone comes in with this exercise pain. How do doctors sort out CECS from everything else?
That's key, the differential diagnosis. The classic story, young, active person, pain that reliably comes on with exercise, points you in that direction. A big one to rule out is popliteal entrapment syndrome, PES.
How's that different?
Symptoms can be similar, but with PS, you often find the pulse in the foot weakens during certain leg movements. You usually don't see that with CECS. Vascular studies can help check for artery compression, too.
What else is on the list?
Well, you've got to think about stress fractures, obviously, and shin splints, medial tibial stress syndrome. Physical exam, maybe x-rays or a bone scan, can help sort those out. Much less common, but you might consider things like cystic adventitial disease or Berger disease, though they're pretty rare in this age group.
Got it. So let's talk anatomy for a second. What are these compartments?
Right. The lower leg has 4 main ones. You've got the anterior, the lateral, the superficial posterior, and the deep posterior. Each is like a tight package with specific muscles, nerves, and blood vessels inside.
And knowing these helps locate the problem.
Exactly. The anterior, that's got the tibialis anterior muscle, the ones that lift your toes, the deep peroneal nerve, anterior tibial artery, lateral compartment, peroneus muscles for turning the foot out, superficial peroneal nerve, superficial posterior, that's your main calf muscles, gastrocnemius and soleus, plus the sural nerve, and then deep posterior holds the tibial nerve, posterior tibial and peroneal arteries, and the muscles that curl your toes down.
Okay, that anatomical map makes sense. So how does this actually look when someone has it? The clinical picture.
It really boils down to those consistent symptoms. Pain comes with exercise, goes away with rest, in someone young and active. And their story, their exercise history, might give clues about nerves being affected.
Like weakness.
Yeah, like if the anterior compartment's involved, they might mention weakness lifting their foot up, dorsiflexion. Lateral compartment issue, maybe numbness on top of the foot. Posterior involvement, which is less common, could mean weakness pointing the toes down.
And what about a physical exam? What would a doctor find?
Well, interestingly, when the person is resting, the exam is often pretty normal. The compartments might feel a bit firm or tender if you press on them. Sometimes you can even feel little bulges, fascial hernias. A really focused nerve check for the suspected area is important, looking for subtle signs of nerve irritation. But, crucially, their pulses in the feet will be normal, and their resting ankle brachial index, that blood pressure comparison, will also be normal. Rules out major artery blockages.
So exams can be subtle. What's the definitive test then?
The current gold standard is actually measuring the pressure inside the compartments directly. Invasive measurement.
Invasive means?
Needles, yeah. Using a handheld device, often a Stryker catheter, to get a pressure reading, an ICMP. There are classic criteria, the Pedowitz criteria, for diagnosis based on pressure levels before, right after, and 5 minutes after exercise.
Specific numbers.
Yeah, like 15 millimeters mercury or more before exercise, over 30 1 minute after, and still above 20 5 minutes after. Something like that.
Is the exercise part standardized? How do they make you exercise?
That's a good point. It has varied a bit in studies. But a newer protocol from Roscoe in the UK involved continuous pressure monitoring while the person exercises on a treadmill until they hit their maximum pain. That seems to be more sensitive, captures the dynamic changes better.
Needles in the leg. Any less invasive options being looked at?
Definitely. People are working on it. MRI has shown some promise. One study by Ringler found a specific measurement on T2-weighted images correlated pretty well with the pressure readings.
Advantages to MRI.
Yeah, it can also show things like if the fascia is thickened or if there's swelling, edema in the muscle, or muscle enlargement. Another technique is NIRS, near-infrared spectroscopy. It measures oxygen levels in the tissue. Some studies show its sensitivity is similar to MRI.
But for now,
For now, yeah, measuring the pressure directly, the ICMP, is still considered the gold standard for diagnosis.
okay, so let's say someone gets the diagnosis. What's next? What are the management options?
Right, management. Well, the first thing often suggested is, cutting back or stopping the activities that trigger the pain.
Which works for the pain, but
Exactly. For dedicated athletes, military personnel, that's usually not a realistic long-term fix. They want to get back to their activity.
makes sense. So what else is tried non-surgically?
People have tried lots of things. Shoe inserts, orthotics, running on softer surfaces, physical therapy, ice, heat, anti-inflammatories like NSAIDs, even local anesthetic injections.
Any luck with those?
Honestly, the consensus is they have pretty limited success in getting people back to their previous level long term. So really, surgery compartment decompression is seen as the most reliable way to achieve that.
Surgery becomes the main option then. What does that involve?
It's called surgical compartmental release. The whole goal is just to decrease that high pressure by basically making the compartment bigger, giving the muscle more room.
How do they do that?
There are a few ways. Subcutaneous fasciotomy, endoscopic fasciotomy, or an open fasciectomy where they actually remove a strip of fascia. Studies suggest the results are pretty similar between these methods. It's usually done as an outpatient procedure, can be under local anesthetic, regional block, or general. Afterwards, they'll put on a compressive dressing and often recommend compression stockings for a couple of weeks.
Can you describe the techniques a bit more? Like for the front and side compartments?
Sure. For anterior and lateral, one way is the Rutherford method, 2 small vertical cuts over each compartment, then cutting the fascia underneath. Or a single longer cut, and they release the fascia under the skin with special tools. Sometimes just 2 small crosswise cuts for a subcutaneous release. Or they might do an open fasciectomy, take out an actual piece of the fascia, and make cuts further up and down too.
And the back compartments?
For the posterior ones, usually vertical cuts on the inner side of the calf. Got to be careful to protect the saphenous vein and nerve there. Then they open the fascia over the superficial and deep muscles. For the deep one, they often have to release part of the soleus muscle attachment to get good access to that deep fascia.
You mentioned endoscopic release too, minimally invasive.
Yeah, that's like keyhole surgery. Uses tiny incisions. They insert a balloon to create space under the fascia, then use a camera and small instruments to see and cut the fascia, interior, lateral, superficial, deep posterior, all through those small ports.
Okay. After the surgery, what's recovery like?
Usually patients are encouraged to start moving pretty quickly. Range of motion, light stretching, early walking is good. No major weight-bearing restrictions typically.
But take it easy at first.
Yeah, definitely avoid vigorous stuff for the first couple weeks. Let the skin heal. Then a gradual return to full activity over maybe 6 to 8 weeks is the usual goal. Depends on the person, of course.
Any common problems or complications after surgery?
The most common issue, though still relatively infrequent, is some temporary nerve trouble. Specifically, irritation of the superficial peroneal nerve. Happens maybe up to 5% of the time.
Okay.
Other things like infection, fluid collections called seromas, blood collections or hematomas, blood clots like DVT, wound healing problems, those are generally quite rare.
So we've got the diagnosis, the treatment. What about the results? How well does the surgery actually work? Is it a slam dunk?
That's a really important question, and the answer is it's variable. While surgery is the best bet we have right now, the outcomes aren't always positive across the board. And it's tricky because studies don't all report success the same way. You see some older reports claiming nearly 100% success, but more recent studies, sometimes success rates are below 50%.
That's a huge range.
It really is. Remember that military group? About a quarter couldn't return to active duty after surgery.
Right.
Although, interestingly, patient satisfaction often seems quite high, maybe around 84% in the short to medium term, even if objective results vary. Overall, the estimated clinical success is probably around 66%, 2/3.
And what about symptoms coming back?
Recurrence happens in maybe 5 to 10% of people. And about 6% might end up needing another operation, a revision surgery.
Why would someone need a second surgery?
Usually, it's either because the first release wasn't complete, didn't fully decompress the compartment, or because significant scar tissue formed afterwards, kind of recreating the problem.
Are there ways to predict who will do well with surgery?
People have looked into that. It seems pretty consistent that if the posterior compartment is involved, the outcomes might not be as good.
Okay.
And, maybe surprisingly, how high the pressure was before surgery doesn't seem to predict how satisfied people are or if they get back to their sport.
Interesting. Anything else?
Yes, a couple things. Having symptoms for a longer time before surgery seems to be linked to worse outcomes. Get treated earlier seems better. And also, some studies suggest female athletes might not do as well as male athletes after surgery. We don't really know why that is yet.
So, pulling this all together, what are the main takeaways about CECS?
Well, it's this uncommon but definitely important cause of leg pain with exercise, especially in younger, active folks. Vascular surgeons need to know about it. It's different from typical claudication in older people. The exercise trigger is usually more intense.
Right.
And crucially, just telling these patients to stop being active, that's generally not a practical solution for them. And the big point about treatment. Surgery is the main option, but even though the procedure sounds straightforward, the results aren't always predictably great. Lots of factors influence success.
That's a really critical point. That variability in outcomes and these unanswered questions like why female athletes might fare worse, it really does underline that we need more research, right? To really figure out how to improve treatments and get more consistent, better results for people dealing with this.
Absolutely. We've learned a lot, but those questions show there's still work to do to really optimize care for everyone affected by CECS.
Well, thank you for walking us through all that. It's been a really thorough deep dive into chronic exertional compartment syndrome. Hopefully this gives you, our listeners, a much clearer understanding of this complex issue.